Hello everyone, and welcome to our third series of educational videos on the 7 C's of the aims of the diagnostic workup of CSU. And today we will touch on the course of CSU. I am Dr. Iman Nasr, consultant immunologist and allergist and head of the UCARE Center at the Royal Hospital in Oman. And with me is Dr. Al-Ahmad, consultant immunologist and allergist and head of the UCARE Center at Rashid Allergy Center in Kuwait. So welcome, Dr. Muna.
Hello, Dr. Iman, and thank you for this nice overview that we're going to have. I'm really looking forward for the discussion and sharing these important highlights about the course of the CSU and the treatment.
That's great. So may I ask, how long does chronic spontaneous urticaria last for? A very common question from patients, and we need to help physicians answer that.
Well, the problem is really chronic, and we are talking about patients that might suffer for a few days and few weeks. As it implies, chronic spontaneous urticaria indeed is chronic. So on average, it's about 5 to 7 years that the patients will, some patients might recover much easier and much shorter than 1 to 5 years and might extend. However, the majority from this timeline course that shows on the diagnosed CSU patients population, about 50% will resolve within 6 months from the onset. And we have much less, about 20% will resolve within a 3 years interval. And similarly, about 20 years will resolve within 5 to 10 years. And much less as we extend beyond the 10 years. And very, very few patients might even have their urticaria flare or activity might persist, beyond the 10 years or 50 years interval. As you can see here, this summarizes really the activity of a chronic urticaria among, as we said, about 1 to 5 years. And you can see here in terms of the population with the most activity, it's really quite common earlier within the first until the 5 years of the course of the disease. And this has been taken from the AWARE study.
Right. So are there any factors that can predict the duration and severity of CSU?
Well, Dr. Iman, as you know, this is an excellent question, and we are asked on a daily basis in the clinic about what are the factors that contribute in each individual or each patient. The studies have shown that the duration usually 1 to 5 years. However, some might have much longer course, and that's specifically if the disease is more severe, if they have concomitant angioedema. You know that angioedema might be associated with the urticarial hives in about 40% or so, if they have an associated inducible urticaria. And if we do an autologous serum skin test in the clinic and we found a positive response, that usually implies that the patient might have the longer interval of his chronic spontaneous urticaria variant.
Interesting. So are there any tools that the physician can use in order to assess patients' disease activity and disease control?
Yeah, there are a number of tools, both for the hives, for the wheals part, and also for the angioedema. And luckily nowadays we have a number of these tools that are available, and they've been translated to so many languages available for the physician in the clinic to be used, and also quite handy, whether it's a paper format, whether it's electronic format, that we can share it with our patients. If we focus on the hives, there is a tool that is well known for physician in the field, known as the Urticaria Activity Score, where we can really monitor the activity of the disease, or the UAS. And similarly, there is the quality of life assessment that is quite specific for the chronic urticaria. It's known as the chronic urticaria quality quality of life questionnaire. Similarly, for angioedema, we have the angioedema activity score, the AAS, and the angioedema quality of life questionnaire, the AE quality of life. Now, if we categorize them according to assessment in terms of disease activity, so then for the urticaria, we have the urticaria activity score, and then we can do it over the 7-day interval. And we have the angioedema activity score. For tools to monitor disease control, we have the urticaria control test. And similarly, we have the angioedema control test for the angioedema. And when it comes to quality of life assessment, we have the quality of life that is quite specific for urticaria, that is the chronic urticaria quality of life. And we have similarly angioedema quality of life questionnaires. Now, if we focus on the urticaria activity score, the UAS, and the angioedema activity score. Many of you are quite familiar with this. This is the urticaria activity score is a validated daily measure. It can be done daily or it can be done over a week. That is the 7-day UAS, and it helps in assessing the urticaria severity and also to monitor treatment outcome. And it covers both the hives and the wheals with a scoring system. 0 to 3 that applies to the hives, staging from mild or none into an intense. And also on the other side, the itch or the severity score, or what's known the ISS, scoring from 0 to 3. So the maximum score you can get from the hives and the itch score is about 6 per day. And if we have the sum of these score over 7 days, it's about 21 maximum. And then if we calculate it over a 1 month interval or 4 weeks, we're ending up with 42 score. That is the maximum of the US over 4 weeks interval. Now, the same thing, and this is just to emphasize the scoring, and this is really categorized according to the severity. Of course, it's a common sense that the higher score means more severe disease. So the 28 to 40, it's a severe disease, while 16 to 27 implies a moderate disease, where it's usually typically with a troublesome itch, and up to, for example, 50 hives. And when we're talking about mild disease, we're talking about the score 7 to 15, and less than that, we're talking about well-controlled urticaria. Similarly, if we apply this to the angioedema activity score, again, this score implies 5 questions that are scored from 0 to 3 after you score yes or no to have you had a swelling episode in the last 24 hours. And we really use it to assess and monitor the activity and the severity of these patients that they have angioedema associated with the disease. And the maximum score that can be reached on a daily basis is 15, which is the summation, a maximum of a 3 for the 5 question. And if we do the AAS over 7, we can reach maximum of 105 scoring. And then again, if we do it to cover 4 weeks interval, we have a score from 0, the lowest, to the maximum for 420. And this just to summarize exactly what we're expecting in terms of the wheals and pruritus when we talk about the UAS, and what we have in terms of the AAS. Now, looking at the other control tests or the control measures that we have to really assess how the disease is being controlled, the urticaria control test, the UCT, and the angioedema control test, the AECT. Now, the UCT is a quite simple questionnaire or a scoring system. It's composed of 4 simple questions that highlight the control of the disease over the last 4 weeks. And usually it gives a scoring where the maximum is between 16 points, and the cutoff for well-controlled is between 12 and 16 possible points. Now, angioedema control test is a similar control test. It's also a very simple, composed of 4 simple questions looking at the control of angioedema as a symptoms that the patient might have over the last 4 weeks. And again, in terms of the scoring, anything that is 10 or more implies a well-controlled disease, and a completely if they have the full scoring of 16 points. Now, when we come to the quality of life tools, and we have something that is specific for the chronic urticaria and something specific for the angioedema measurement, and these tools are also quite handy and available in the clinic to be used. If we look at the quality of life questionnaire, there is one that is quite standard for the Dermatology Life Quality Index, the DLQI, and this is quite famous and it's well standardized, and it covers really a number of domains, covers 6 domains: the symptom and feelings, the daily activity of the patients, leisure time, work and school, personal relationship, and treatment. And this can be used across different diseases that really are common for the dermatology specialty. However, we have a quality of life questionnaire that is quite specific for urticaria, in particular chronic urticaria, and that's the CU quality of life. And there are also a number of questions. It's about 23 questions related to the itch, wheal, the swelling, the angioedema of the eyes and lips, and then covers different domain, as we said, as we've seen in the dermatology score, the work, the physical activity, sleep, the free time, social relationship, and eating, and really try to monitor these different domains. Now, similarly, the angioedema quality of life questionnaire also covers more or less the same domains, and it comes up with a score where we can assess the patient's quality of life at the end, just to see the impact of chronic urticaria on his life. Now, enough been said about the tools that we have, but now, as we have seen, Dr. Iman, from the course of the chronic spontaneous urticaria, what are the treatments that can be started for these patients, and are these treatments helpful in terms of curing the disease or only suppressing symptoms?
Thank you very much, Dr. Mona. Very important question. Very excellent. So chronic urticaria will run its course. So there's no really cure for it as such in the majority of cases. And the goal of the treating patients with chronic urticaria is treat the disease until it's gone. The aim basically is to control symptoms that result from the release of histamine and other mediators by the mast cell and basophils. And our target is an urticaria-free reaction. So the management of CSU is basically to avoid triggers such as drugs, which is non-steroidal anti-inflammatory drugs, maybe triggers, physical triggers such as cold, vibration, pressure. Stress management is really important. Any underlying cause such as thyroid disease or Helicobacter pylori should be treated, hoping that that will control the urticaria. There is a question about diet and food, pharmacological therapy, and in some cases, induction of tolerance. So to touch on the first one, which is avoidance of trigger, we know that there are triggers that can flare the urticaria and even prolong its course. And the idea is to shorten it and control it as much as possible. Stress being a major factor and major trigger. Food, drugs, and infections. And infections would be mainly parasitic infection, viral, or even bacterial infection. Now, the underlying cause, as we said, thyroid disease and Helicobacter pylori. Sometimes when controlling these conditions, the urticaria is controlled, and there might be even no need to start medications in such patients. As for the diet, IgE-mediated food allergy is really rarely the underlying cause of chronic urticaria. If identified, we eliminate it, and we expect resolution of urticaria within 24 to 48 hours. And in fact, it should not come back again if it's really related to an IgE-mediated food allergy. However, pseudo-allergic reactions are considered in some cases where it is a non-IgE mediated hypersensitivity reaction to naturally occurring food ingredients, and in some cases food additives. In this case, the patient is put on a pseudo-allergen-free diet for 3 to 6 months with the help of the dietitian, and we expect a response from at least 3 weeks. It is important to know this is controversial and yet unproven in well-designed double-blinded placebo-controlled studies.
So, Doctora, this is amazing. And if we cannot really avoid, and in most cases, patients cannot really identify the trigger, what do you think the available treatment that we have, and whether there are certain tools we can incorporate, like patient outcome measures, we can incorporate it for the treatment?
Wonderful. So yes, there are pharmacological therapies out there, and I'm bringing the most recent guidelines, the AECT guidelines in the treatment of urticaria, which is published recently in 2021, last year. The recommended treatment is to start with second generation non-sedating antihistamines. We start with 1 tablet, and if needed, we can increase the dose to 2, 3, up to 4 times every 2 to 4 weeks, but earlier if symptoms are intolerable. If this is not helpful, then we go to the second line where we add second generation H1 antihistamine blockers with omalizumab. So this is a anti-IgE treatment. It's a biologic, and the standard dose is 300 milligrams every 4 weeks. Now we can increase the dose and or shorten the interval based on the patient's symptoms. We can go up to 600 milligrams every 2 weeks, or 5 milligrams per kg body weight. Now, if this does not control the urticaria within 6 months or earlier, if the symptoms are intolerable, this is where we add cyclosporine to the omalizumab and the second generation antihistamines. So this is where you asked me, can we incorporate patient outcome measures? So yes, we can. We take the patient, the simplest one is the urticaria control test, where we take the patient's control of the urticaria score. And we remember from your presentation that the best is 16 points. Control is between the cutoff value 12 to 16. Anything below 12 is uncontrolled disease. And this is where it falls in the urticaria guidelines. So if the urticaria control test score is less than 12, this is where we say this is uncontrolled and step up. So if the patient is on 1 dose of antihistamine, increase to 2 or 3 or 4. If the patient is on omalizumab after 3 months and the urticaria control test is less than 12, this is where we increase the dose or shorten the interval based on the patient's symptoms. If the urticaria control test is between 12 to 15, so this is controlled, we continue the therapy and probably try to optimize if needed. If the urticaria, once the patient reaches an urticaria control test score of 16, then this is called completely controlled, and then we consider stepping down on the treatment, of course, based on individual factors, so either by reducing the dose or extending intervals. So what is IgE? What is omalizumab? It is a monoclonal antibody directed against the IgE. It tends to bind with the IgE and deprives the mast cell from interacting with it. It is an add-on therapy for adult and adolescents from 12 years and above, for those who do not have an adequate response to H1 antihistamine treatment. So this is how it works. The omalizumab basically prevents the IgE from binding. So this is where our allergen binds to the IgE receptors on the Fc epsilon receptors on the mast cell, causing histamine release and causes key symptoms of hive itch, reflex edema, and angioedema. Reflex erythema and angioedema. Now, omalizumab is the colorful antibodies here. So 2 molecules interact with 1 IgE, inhibits the binding to the allergen and as a result binding to the Fc epsilon receptors on the mast cell, and this obviously will cause downregulation. The dosing, as I've mentioned, is 300 milligrams every 4 weeks. The dose that can be, the maximum dose that can be reached is 600 milligrams every 2 weeks. Now, a higher responder are those who have the type 1 autoimmune CSU, so the higher the IgE, the better. Low IgE will predict probably that this patient will be a non-responder to treatment. And what's very useful is to have an IgE at baseline and an IgE after 4 weeks of starting omalizumab. If it doubled at week 4, this means that the patient will most likely have a good response to the treatment. Now, other treatments of CSU is the calcineurin inhibitor, cyclosporine, a dose of 3.5 to 5 milligram per kg per day. There are side effects of hypertension and renal impairment for which we need to monitor. Although we know that cyclosporine has side effects, but please remember it is far better risk-benefit ratio compared with long-term use of steroids. We use corticosteroids only for acute flares. So the dose between 20 and 50 milligram per day of prednisolone. Other treatments, such as leukotriene inhibitor, has low evidence. The best is for montelukast. Topical steroids, not really helpful in CSU, except probably pressure urticaria on the salts, but this has low evidence. Other treatments reported in case studies, H2 antagonist, dapsone, sulfasalazine, methotrexate, interferon, azathioprine, hydroxychloroquine, IVIG, but all of these are case reports. And despite the lack of published evidence, they may be tried at in individual patients in appropriate clinical context. There is induction of tolerance, where in some types of urticaria, we might expose the patient to the trigger. And in this case, it may work. There are good outcomes in this, but unfortunately, daily exposure to this stimulus might be very difficult, such as daily cold bath and cold urticaria.
What about any new medication that we have, especially for those who are resistant to the biologic?
As for the new biologics, which is the question, yes, it is exciting. We do have omalizumab, we do have ligelizumab, and ligelizumab is a super omalizumab. It is 40 to 50 times more powerful in binding to IgE than omalizumab. And this is now in the market. We have others. So as you can see, this is the mast cell with certain receptors here. And the aim is to target these receptors which cause the mast cell to release all the mediators responsible for urticaria, histamines, leukotrienes, and prostaglandins. We have Siglec-8, so we have an anti-Siglec-8, lirentelimab, and we have dupilumab, anti-interleukin-4 receptor antibody. We have also targeting the Bruton tyrosine kinase, which is fenebrutinib. So basically, these are the treatments, and hopefully with all of this, our aim is to control the urticaria as much as we can.
Thank you very much, Dr. Iman. That was a comprehensive overview, and I hope that everyone have learned the course, the tools that we can use, and also the treatment, with the hope that we have more treatment available for treating the refractory cases.
Thank you very much.
Thank you.